Welcome to Weedy's Summer Forum.
It's a real pleasure to be here. I enjoy my participation and seeing my colleagues, and let's have a little fun for the next 15 minutes or so. So we can start off by just sharing the challenges that we'll have in a few minutes about absorbing what we have learned about fire in the last 6 months, and we'll try to do this as efficiently as possible. I did want to start out with something personal. So why would I be involved in this? Well, I left NIH and went to the Lombardi Cancer Center, where I spent the next part of my career. It was a challenge taking care of those patients because of the inability to exchange information as seamlessly as we had. The problems that caused has dramatically shifted the landscape. We now realize that medical errors are the third leading cause of death in the United States. And I wanted to tell you very briefly about Jack. This is a true story. Jack was my patient, and he was kind of a high school hero of sorts. And he went to his doctor complaining of knee pain. And this is what his knee x-ray looked like. You don't have to be a radiologist to read it. That's a mess in the knee. This is the chest x-ray when I saw Jack. And the biopsy was metastatic osteosarcoma.
Recording in progress.
Okay, what do you want me to? Oh, I still see that. Sorry, it's blocking my screen. Okay. And so early on in my career, I thought that information sharing is critical if we're going to take better care of our patients. And the rest of the morning, I'm trying to focus on how we'll do that. The story begins late in the 20th century when we discovered that APIs were what drive commerce, banking, travel, information exchange. But it wasn't the way health information was shared. And you've probably had dozens of discussions about fire and what it is and how we use it. So I wanted to talk about some of the advances that we've made. So this is a fire timeline. You may have seen it. Fire is now 12 years old, and it began as a concept of sharing information with APIs, and it got an enormous boost when Apple embedded it in the operating system, and ONC decided that fire was the future of healthcare interoperability. And now healthcare regulation in the United States and around the world is predicated on fire implementation. This is just a modification of that timeline that highlights some of the critical steps in fire implementation and regulation. To be certain, there are some valuable moments when agencies identified the next step. And I think CMS's rule that fire endpoints were required in all electronic health records starting in January was the key that this commitment would be honored. But fire is really a whole lot more than just the endpoint. This is a graphic representation of all of the elements of the fire platform. Certainly, there's SMART that ensures authentication and security. There are the implementations that are regional, and there are those that are global, like the WHO requirements. And And lastly, there are our national requirements, such as the evolving prior authorization capabilities. What I'd like to talk about is how these changes have come about. I think for the most part, HL7 was about standards development for more than 3 decades. But within the last 2 years, we've developed an implementation division. And this is really at the heart of our transformation from standards development to making standards usable. At the center of this spiral created by Diego Kaminker are the 200 to 2,000 FHIR developers around the world that are focused just about creating the specification. But around that and going out are the tens of thousands of entities that implement it, not only in the US, but worldwide, and the hundreds of thousands or millions of entities that use it. Most of the clinicians around the world don't care about resources and implementation guides. They just want it to be effective in the way information is delivered at the point of care. This really highlights some of the capabilities of FHIR and the interaction between the standards development and the standards implementation. And at the heart of this is the testing and certification of the FHIR standards. Does it work? How does it work? And what consistency can you rely upon to ensure that it's usable in the form that it is meant? Now, at no point will we identify whether it's accurate, meaningful, or going to change the course of patient care, just whether it complies with the FHIR spec. We wouldn't have been successful were it not for the collaboration that we've enjoyed over the past decade. The hundreds of thousands of people who contribute to the process, not the least of which were the 8 FHIR accelerators who are committed to the implementation of the FHIR spec in a meaningful way within their domains, the vertical information that's needed, and across domains for the sharing. The information that we collect in patient care is the same information that we need in clinical research or in public health. Amongst the FHIR accelerators, the first and perhaps foremost was Argonaut. It began by Mickey Tripathi after he enunciated that APIs were the future of interoperability during the JASON Task Force report in 2014. And FHIR has grown dramatically through the contributions of Argonaut. And I think whether you recognize platforms like CDS hooks or the integration in the Apple Health Kit, I think there are some important developments that Argonaut contributes to make, including a current project on delivering imaging through a FHIR API. And of course, the Da Vinci program, which was the second. It was remarkable because as a clinician, we probably sued Blue Cross Blue Shield of California 24 times. And here we were sitting around the table agreeing that really the key to improve patient care at lower costs was the seamless exchange of health data. Da Vinci has grown dramatically over the past 4 years to include dozens of collaborators, including the providers, the electronic health record developers, the enormous payer community who relies upon the clinical data, and the virtuous cycle of returning that information to the providers, which is so key to prior authorization. This is a dashboard developed by Viet Nguyen, and it really highlights some of the remarkable programs and progress that's been made by Da Vinci, and of course the Holy Grail that we'll talk about in the rest of the hour about prior authorization in the upper right-hand corner. Codex began as an oncology effort, both patient care and research, but has since grown to include cardiology and genomic data. And I think the remarkable thing has been not only the identification of data elements, but the application of that information at the point of care or in research development. Not only the creation of electronic case report form or patient recruitment, but also the design of the clinical trial. FAST emerged from ONC. They had nurtured FAST for 3 years before they brought it into HL7. Don Rucker insisted on changing the name to FAST because he could never remember the acronym that ONC had used. But really, FAST transcends all of the other fire accelerators by enhancing the infrastructure by which the data exchange is promoted. There are, and for the other 5 fire accelerators, if you participate in them, you can berate me later. The government agencies, certainly ONC with the Cures Act final rules and the elements there that defined what fire was and shall be. And we promote the evolution of fire predicated a large part on this. And for those of you who wish, you're welcome to all of these slides. And of course, CMS for their burden reduction program. And I think when we're able to embrace the concept of prior authorization, not only will the clinical community and the payers benefit, we won't have to wait a month, but if you're authorized to obtain an image, you'll be likewise authorized to do any procedure predicated on the results of the image and perhaps authorized to have physical therapy based on the outcome of the procedure. But it really goes more than simply ONC and CMS because we collaborate with the other agencies who have their own unique programs for fire standards adoption and integration within the framework of their unique communities. The fire community is really a concept that we have. It goes beyond the work groups, the individuals who develop fire and implement it. It's the large community outside of HL7 in a larger sense. The people who need to use it and have a feedback loop that informs us about the process we need and the steps we need to ensure that it's successful. And of course, there are a host of other standards development organizations. Some are ANSI organizations. Others are critical to the process by which we implement fire, we measure fire outcomes, and we utilize the capabilities not only for vocabulary, but for uses that go beyond patient care. Harvard, Boston Children's continues to enhance the SMART platform. Not only do they provide a repository for Smart on Fire apps, but they also continue to develop artifacts like bulk data on fire, CDS hooks, and other critical capabilities. NCPDP on fire is a unique interest area in which we'll probably see in the next year the integration of brick and mortar prescribing within a fire platform. And OMOP on fire. They said this can never happen because Odyssey has a completely different data structure than fire. So we use the OMOP data model, the fire data elements, map between them, and we have a far enhanced program for clinical research. We wouldn't have been successful without the professional society. Only last month we announced that CPT from the AMA would now be available in 50 countries to use for fire testing and implementation. But all of our partners in professional society have contributed the next steps. One of the unique things about fire and all the other HL7 standards is we give it away. It's not a great business model. It's hard enough to sell it if it costs nothing. The big showcase events have supported the evolution of fire, and it has served as a sounding board for both the needs and the contributions made by for-profit and not-for-profit organizations, both in the US and globally. It would never have been successful when I announced the in January 2015 about the Argonaut project. I had more tweets that day than I have ever had. Someone said, Jaffe's out of his mind. You don't mean to tell me that Oracle and Epic are going to be, well, Cerner and Epic are going to be talking to one another, and yet they participate in Argonaut on a daily basis. And it's a real pleasure to see the progress that's made by the collaboration not only of those EHR vendors, but others like InterSystems and SureScript. I think as we move forward, we'll see a host of other organizations supporting not only the implementation and the integration of fire, but also contribute to the feedback. What do end users need, and how can we adopt them for use and integration within the fire platform? And it's growing, and we rely on this feedback for the future development, as well as a host of non-government organizations that over the last 2 or 3 years have been a focal point for understanding the value that it brings, the diversity that's available, and contributing to the way patients benefit from adoption. I think I was most excited about 4 or 5 years ago when the cloud vendors all got up on the stage and said they were going to exchange information between clouds and from providers to the clouds using Fire APIs. And now, last year, they announced the same would be true with bulk data on Fire. One of the cloud vendors explained how they imported 600,000 records into a repository and were successfully able to predict hospital readmissions for congestive heart failure or emergency room visits for degradation of diabetic control. Lastly, we've begun to embrace a large community of patient advocates. It's been a game-changing experience to have them. And at the last work group meeting in May, the patient advocates contributed to the growth and refinement of the way fire is used and what it means to them. We're now participating in a program called CHAI, the Coalition for Health AI, or if you're conversant in Hebrew, I guess it would be Chai, which ironically is the word for life. But CHI is emerging for their interest, a large, diverse group of developers, providers, NGOs, and others who feel that the value of AI has to be weighed against the risk of AI within the healthcare continuum. In September, we're going to have the entire plenary devoted to AI and have a host of prominent global speakers talk about the value, risk, and the policy determinations that enable generative AI within healthcare. We also partnered with DARPA to try and harden FHIR endpoints, FHIR utilization, enable better utilization of HIPAA and other requirements around security and privacy. And lastly, and one of my favorite quotes about taking chances, we're about to have a host of rollouts of actual products that support patient care and delivery within a digital insurance card, the Sync for Social Needs, enabling FHIR for access to a host of information within the cloud. And I think over the next 2 years, we'll see a diminution of client server systems and moving health information to the cloud, including imaging, which is critical. I can tell you that within San Diego, the best way to get an image from Scripps to Sharp is put it on a DVD and carry it across the street. And lastly, here are a host of links that you can see where the cloud vendors have partnered to share health information using FHIR endpoints. In the next year, we'll see the emergence of R5. Release 5 is more than a normative standard. It really embraces the evolution of FHIR over the past decade. And I think the future really lies in subscriptions. R4B included subscriptions, but now in R5, it enables you to have a continuum of health information, whether it's laboratory data, clinical emergence, patient reported outcomes, and other events that are so critical to decision making and policy evolution. So let me just highlight that over the next month, there are going to be a host of FHIR training events, a number of online courses, many of them freely available. And with ado, I say thank you, and I look forward to discussing these things with you the rest of the day. So thank you. Our next speaker is going to be available virtually. Kirk Anderson, who is the VP and Chief Technology Officer at Cambia Health, is going to kick off the session on the advances in the next steps of prior authorization. So without further ado, Michael, can you switch over to the Zoom? Okay. Thank you. Thanks, everyone.